Thank you for joining us. My name is Dr. Len Appleman. I'm a GU medical oncologist at the University of Pittsburgh, and we have a panel here, Dr. Priyanka Chablani, also from the GU group at the University of Pittsburgh, Dr. Risa Wong from our group here at the University of Pittsburgh, Dr. Zara Kelly also, and Dr. Dhaval Mehta from our community practice in the Monroeville area, who sees GU cancers as well as a lot of other cancers that I'm not smart enough to understand. So I think we have a lot of interesting abstracts to discuss from ESMO this year, a lot of interesting data to digest, and most importantly, think about how it will be applied to our clinical practice. Before we talk about the exciting therapeutic advances in the field, we wanted to start off talking about what's been a real revolution in prostate cancer imaging with the PSMA PET CT technology. I can remember when fluoride PET and fluciclovine PET scan came out for prostate cancer, they never really caught on because they really didn't necessarily change our management relative to the information we got from traditional CT and bone scan, and sometimes they could even be a little distracting or confusing. I think since the PSMA PET scans have come out, I've been surprised at how much I've been using it, how many situations it seems to be really helpful in. And so I wanted to open up to the group, how has it changed your practice?
So I would start as in a community seeing multiple cancers. I always struggle when I have a patient who comes from early stage localized. I just saw a patient today, intermediate risk, unfavorable, and I ordered a PSMA PET at a high risk prostate cancer as a baseline. Once we go to the metastatic setting, I tend to do at least once at the diagnosis before they end up going on AR agonist, chemo, or combination. But I'm just struggling, and I would be curious to know all the experts here to weigh in and share how are you using, how often we are doing the PSMA PET along the treatment pattern.
And I can say, I do think it's changed practice, and there are certain circumstances that we use them in. I think, what really has changed it is, a lot of the trials that led to the approval of these systemic agents used conventional bone, used conventional CT, and now we're in this new era where we're picking up with these hypersensitive imaging modalities, disease that wouldn't conventionally have been picked up. So I think you kind of have to interpret those old trials with kind of a grain of salt. And then I also think there's just a lot of nuance to interpreting those scans. I'm sure, reached out to our radiologists just to say, hey, this is super sensitive and it's picking up this tiny SUV, and what do I do with that information? So I think there is nuance, but I agree, in high-risk patients, certainly in the localized disease setting, we are using it. Our urologists are commonly using it to help us as well before patients make it to the medical oncology setting. And then I agree, I use it, depending on the clinical scenario, oftentimes once. It's usually ordered, like I said, by our urology colleagues. Then subsequently, if it's not going to change management, there's a nice response. I'll oftentimes use even conventional imaging, depending on the scenario, but I think it's very patient dependent.
Yeah, I would echo everything that's been said. I think for localized prostate cancer, especially for unfavorable intermediate risk or high risk prostate cancer, it gives you more confidence that you're doing the right thing. It can sometimes help guide radiation if there's particular spots that the radiation oncologist might want to target with curative intent. I think it has led to a lot more metastasis-directed therapy for people who have biochemical recurrence, for example. That's a prime example of patients who before maybe would have been put on intermittent androgen deprivation, but with PSMA PET, if they only have a few sites of disease, you might target those with SBRT. And I agree with what Dr. Kelly said about there being some nuance with the interpretation. I did have a patient recently who had high-risk localized prostate cancer, had a PSMA PET scan that was read by the radiologist as having actually diffuse metastatic disease, but then when you looked at the actual scan, the lesions that were called were very low SUV, and I wasn't convinced. So he had been given an incurable cancer diagnosis, but when I talked to our nuclear medicine colleagues, they thought really that was an overread, and he could actually be treated with curative intent. So I do think it's very important to have a good interpreting radiology or nuclear medicine department that you can kind of discuss these cases with.